Hey everybody, it's Professor Wells. This is our last chapter that we're going to be going over. Yay, the semester is almost over. You guys have done great. I am proud of you. Let's keep up the good work until the end of the semester, even till next semester. You guys are so close to being done. So let's get going here. So we're going to go over dental implants. Dental implants are one of the cooler procedures in dentistry right now. They're fairly new. Actually, they've been around for quite a bit, but we're seeing more and more of them. A lot of people are becoming more perceptive to getting them, more so because they don't want something that comes in and out of their mouth. They want something that's going to last them a lifetime. So if dental implants are taken care of properly, guess what? They can last a lifetime. So what are dental implants? They are anchors for prosthetic devices that are fixed to the bone. Subperiosteal and transosteal implants are rarely done because of the high success rate of the endosseous implants. Endosseous implants have a component that is inserted into the jawbone to act like a root substitute to support a crown or prosthesis. When placing a subperiosteal implant, first a surgical incision is made to expose the bony ridge by reflecting the soft tissue and periosteum overlying the bone. An impression is made of the exposed bone, and then the surgical wound is closed. Second, a replica is made of the bony ridge from the impression. A metal framework is cast in the laboratory to fit over the bone. This framework has metal projections on it, which the prosthesis will be attached to, and they extend through the tissues covering the ridge. Third, a second incision is made to reopen the initial wound and once again expose the bone. The implant framework is then inserted over the bone and under the periosteum. Overlying tissues are then sutured closed, with the metal projections for the prosthesis protruding into the oral cavity. This approach is rarely used in present-day dentistry and has been replaced by the endosseous implants. This figure shows this older implant style. The transosteal implant is used to support a mandibular denture when the patient has severe resorption and lacks enough bone support for endosseous or subperiosteal implants. A metal plate through which the ends of the rods pass is bolted to the underside of the mandible. A transosteal implant requires both intraoral and extraoral incisions for its placement and stabilization. It's seldom used because of its highly invasive nature. This just looks like it hurts, doesn't it? I don't think I would ever want anything like that. The endosseous implants are the most popular implants currently used today. Clinical studies have shown that these implants to be very successful with long-term survival, longer than 10 years, and approximately 85% in the maxilla and 95% in the mandible have the high success rates. Titanium and titanium alloys are the metals most commonly used because of their biocompatibility with oral tissues. Titanium is a lightweight, corrosion-resistant material. The bone will grow around and fuse to the titanium implants to retain them. And this figure shows the endosseous dental implants. Surgical approaches to implant placement have variations. Part of the decision on surgical approach depends on whether a healed edentulous space is already present or whether a tooth needs to be extracted first. When an implant is placed in two stages, the first stage involves exposing the bone at the chosen placement site with a surgical flap. Next, a hole is drilled into the bone that has the shape and length of the implant cylinder and a size that is just slightly smaller than that of the cylinder. The implant may be lightly tapped into place and have a frictional fit with the bone, or it may be screwed into place, and that's what we see most of the time. After the implant fixture is placed in the bone, a screw is placed into the opening at the top of the fixture. A surgical flap is repositioned and it's sutured closed over the implant. Approximately 3 months later, which is the second stage, the surgeon uncovers the top of the implant fixture, removes the cover screw, and places a smooth prefabricated or custom healing abutment. With the one-stage procedure, surgery for replacement of the implant is performed just as in the two-stage procedure. The difference is that with the one-stage procedure, the top of the fixture projects through the soft tissue at the time of surgery, and a healing abutment is placed at that time. The soft tissue is sutured around it rather than covering it. When the implant procedure involves the extraction of a tooth, some clinicians place the implant fixture at the time of extraction directly into the new socket. This is called immediate placement implant. A soft tissue flap is used to cover the extraction site until bone fills in and integrates with the fixture. Most clinicians wait for healing of the bone around the implant. Others place a provisional crown on the implant fixture immediately after surgical placement. This causes loading of the implant under chewing forces before the bone exhibits healing around the implant. Careful consideration must be made to ensure successful osteogeneration. These kind aren't used that much today because that loading of the implant under chewing forces can cause that implant to fail. So it's better to do the two-step or the one-step implant placement because that gives the bone time to integrate with that implant. The open tray impression is the easiest of it for the inexperienced clinician. With this procedure, a plastic impression tray is tried in for fit to the arch. Then the impression abutments are attached to the implant fixtures. The plastic tray is reinserted into the mouth, and the location of the abutments is marked on the tray. The limitation of the open tray impression procedure is if there is a lack of interarch space to gain access to unscrew the abutments. With the closed tray impression, also called a transfer impression, there is no hole cut in the impression tray. The impression abutments are screwed to the fixtures, and the impression is made using the same types of materials as with the open tray procedure. The biggest drawback of these is the potential source of error if the abutments are not placed back into the impression fully or in their proper orientation. Restoration of the single tooth implant is usually done with the prosthetic crown. With the one or two-stage procedure, once the soft tissue is healed around the top of the implant, the impression for the crown can begin. The implant crown may be attached with a screw or through luting cementation. A lot of us are doing, a lot of the doctors are doing the screw retained implant crowns right now because if anything ever happened, they can remove the resin that covers the screw and take the crown off. Where if it's cemented on, you don't have the ability to do that. So scanners can eliminate the whole impression procedure by taking a digital scan of the area, the opposing arch, and also the bite registration. The lab can use these scans to make a more accurate fitting implant crown. Many implants are smaller in diameter than other implants. They can be placed in sites where the available bone would be inadequate for conventional implants and are minimally invasive in that a flap is usually not needed. One of the main uses for mini implants is to stabilize a denture. Mini implants on an x-ray actually look like little screws. Just an FYI. Mini implants are also used in sites with minimal bone that could not accommodate a conventional implant unless bone grafting was done. Common bone graft procedures are done to increase the width and height of the implant site or to place bone where the maxillary sinus extends too close to the alveolar ridge. Bone grafts are actually pretty cool and they're a lot less complicated than you think. It's literally mixing powdered cadaver bone with I'm not 100% sure on what the liquid part is, but you mix it together and it forms into a little ball. And then you take that little ball with your finger and put it in the extraction site. And that's it. Pretty simple. Autografts are those harvested from the patient's own body. Allografts are human bone taken from donors who have donated body parts at the time of their death. This is the cadaver bone. Xenograft material is obtained from animals, which is usually cows. And alloplasts are inert synthetic materials that stimulate new bone growth. They're commonly composed of calcium phosphate or hydroxyapatite, components found in human bone. Early failure of an implant is usually due to failure of the bone to integrate with the implant itself. Lack of integration can be due to poor surgical technique with excessive generation of heat when the implant hole is drilled in the bone. Failure of the implant that occurs after the initial integration is often caused by bacterial infection extending from the peri-implant tissues into the bone or overloading the implant during function. This leads to loss of the supporting bone. So implants can have bone loss just like a normal tooth. It's the closest thing to a normal tooth, and it still has the same effects. Everything affects it just like it would affect a normal tooth. So these are very important to keep clean, to floss. It's very important that you stress that to your patients. It's critically important to the success of the implant for the patient to employ meticulous oral hygiene techniques and work with the dentist and dental hygienist to implement an effective tissue management program. The dental hygienist plays an integral role in helping the patient maintain the health of the implants and reinforcing home care techniques. Home care should be customized to the patient's needs. A gentle sulcus brush can help maintain the tissue around the implant. Interproximal brushes should be mounted on plastic instead of metal. Flossing should be done as recommended. And then there's balsa wood toothpicks that can aid in plaque removal and antibacterial mouth rinses that can help reduce bacterial load. So part A of this figure shows an interproximal brush that's being used to clean an implant, and that's actually looks like it's an implant supported denture, or it could also possibly be an all-on-4. With an all-on-4, the surgeon places 4 implants in different areas of the mouth. Usually it's not all in the anterior there, but that helps support that denture. It does not come in and out. They're actually very, very nice. They're also very, very expensive. And then part B here shows a nylon coated proxy brush used to clean between individual implants. Sometimes it's too hard to fit a brush like that between the implants. As long as they get in there with floss or even super floss, that would be good. They just have to keep that tissue clean underneath. Hygiene visits should be made as recommended by the dentist. There is no right or wrong way. Usually they put them on a perio maintenance because we want to make sure that that implant is stable. Instruments made of metal should not be used on the exposed titanium implants. Plastic or graphite scalers can be used, even titanium instruments. Medium or coarse prophy paste should not be used as well. Tin oxide should be used instead. In summary, implant dentistry is increasing every year due to their high degree of success and patient acceptance. Patient education about diligent home care is a very important aspect of the role of the dental hygienist, and it's essential for the success and longevity of the implant. So I really hope you guys get a chance to see some of this stuff in a clinical setting. And then I know some of this stuff can be kind of confusing, but hopefully it's interesting to you as it is to me. If you happen to have any questions, please reach out to me. My email is hwells14@ivytech.edu.